Welcome back to another edition of the Hart to Heart Podcast. And my guest today is Dr. Sohail Gandhi. Dr. Gandhi is a family doctor in Ontario, just working outside of Collingwood. Is that right?
That's correct. Yeah, a little town called Stayner.
Excellent. And so how long have you been there for?
Since 1992.
Wow, it's a long time. What kind of keeps you in that place?
The people are great. I'm really very, very fortunate. I have a great practice with really nice people, very, very diligent, hardworking people. It's a great community, and it's really an honor to serve them.
Yeah, I feel, the same way about my staff, and I think that makes a massive difference for, family doctors. And I know we're, going to talk about family medicine today in Ontario, but that's certainly one thing that I know has helped a lot with me in my practice is finding the right staff. And it seems like, it's helped you a lot too. And maybe that's something that
Yeah.
we'll discuss, but for sure, finding great staff and finding good people to work with, just makes you not want to leave. So I understand how you feel because I kind of feel the same way about where I am now. The reason why I wanted to chat with you today, and I think, why a lot of people are probably listening to this is because there's a big shortage of family physicians in Ontario right now. I think there's, going to be close to like 1/4 of people in Ontario now are going to be without a doctor within the next few years or so. And so, I know it's a difficult question to answer, but why did all this happen? Like, why is there such a shortage, do you think?
Well, so a couple of things, and I realize this may seem like heresy to say this, but there actually is not a shortage of actual family doctors, right? What there is there's a shortage of comprehensive care family physicians and people willing to do that. If you look at the Ontario Medical Association statistics on family medicine, we have approximately 16,000 physicians, family physicians in Ontario. They're licensed in Ontario. They know the Ontario healthcare system, and they're able to practice comprehensive care family practice. But only about 9,500 do. And that number is shrinking. And more people who are actually trained to do this are leaving family medicine because of the workload and because of the compensation issues and because of, frankly, the lack of respect from the government that seems to think that other people can do our job, right? And so lots of people talk about the solution being, well, let's get more international graduates, let's increase the pool, et cetera, et cetera. We've got 6,000 people already in Ontario who could do the job if we made the working conditions better, right?
That's
And
interesting.
if even 1/3, just think about it, even 1/3 of them, so that's 2,000 of them, decided to go back into comprehensive care family medicine. Average practice size about 1,200. That's 2.4 million people that are taken care of right then and there, right? And the crisis ends. So our focus has all been on the wrong place. It's all talking about, having other people do the job of family medicine. It's all talking about replacing us with allied healthcare professionals. It's all talking about foreign graduates and all this. And honestly, I think that's nonsense. I think you make the working conditions better. You pay people for the work that they're doing, and you'll get those people going back to family medicine because at the end of the day, family medicine, the actual medicine part is a truly rewarding career, right? Like looking after, for me personally, as I mentioned earlier in the introduction, my patients are wonderful. I really like my patients. They're a good bunch of people. It's been an honor to look after them for 32 years, to watch the children grow up, to watch the families as they've aged, to look after their health concerns as they're seniors. Like to follow them along has been a true honor, and I think it's the best kind of actual medicine. But it's the other stuff that goes along with the job, the difficulty in getting tests done, the difficulty in getting consults done, the fact that I average 85 to 90 messages a day in my inbox that have to be cleared out. Like that stuff. And the fact, quite frankly, that if you look at recent economic studies show that the net income of family physicians has fallen over the past 10 years, it's fallen about 19 to 20%. There was a study by a guy named Boris Crouch, who's an economist out of McMaster University, who studied this. So you got a situation where income's going down, workload's going up, and yeah, I don't care what job you have. That's just a bad combination, right? Like that's just not a good combination. So we need to focus on making family practice more appealing. and then the doctors who are already in Ontario can already do this work without needing extra training. We'll go back to it.
So that's a very interesting statistic, and I certainly didn't know that. So there's
Mhm.
roughly 16,000 family physicians in Ontario who are licensed to practice, but only about 9,500 of them, are you saying, are practicing at all or are practicing within the scope of family medicine?
So, with are practicing within the scope of comprehensive care family medicine. The others are still practicing, but they've gotten frustrated doing family medicine, so they've left for things like, working in hospitals or working only in walk-in clinics or working in, other environments where they don't have to do the challenging and difficult work that comprehensive care family physicians do.
Interesting. And so, that's, I'm not doing the math here perfectly, but I mean, that's well over 30%, maybe 35% or even more of physicians are,
Mhm.
not doing this. And so, has it always been that kind of discrepancy, or is this something that's just been recent? Meaning, like, when you were practicing in 1992, where there are 10,000 family physicians licensed and 10,000 of them all doing comprehensive family care medicine?
No, this is something that's really happened over the past 10 or 12 years. It began, quite frankly, when Deb Matthews was health minister in the Dalton McGuinty government, I believe, and she was the one who first started to say, we're not going to listen to family doctors. And then, of course, Eric Hoskins came and he just kind of carried that on. Um, now there will never be 100% of licensed family physicians who do comprehensive care family medicine, right? Like that's not realistic. But to have a situation where 35-ish% are not doing it, that's really unacceptable. We
And
need to shrink that number.
And you're definitely correct. I mean, just by simple numbers of doing the math, like you add 2,000 family physicians, roughly 1,200 to practice, like you're saying, like that's 2.4 million people, like that now have a new family doctor. That would essentially, solve the issue. So I do think that, your approach of what, why don't we just try to get the people who are already licensed here, to start working again? That seems like obviously the lowest hanging fruit and simplest solution. But in order to do that, I think that we need to look at, from my understanding, just better working conditions overall. So people want to not have to see an insane amount of people. Like I'm one of these people who right now I'm seeing insane amounts of people. Just between yesterday and today, I saw 152 people. It was
Mhm.
82, I think, yesterday and 70 today. And I know, other family docs, that I work with that are very similar too. But, a lot of docs don't want to work like that. And I understand them. There are benefits to, having more time that with your patients and providing, good quality care. And so, how do we entice families, or how does a government try to entice family physicians to stay within family medicine?
Well, and this is the part that really frustrates me about the Ontario government currently, and quite frankly, with the bureaucrats at the Ministry of Health. This is not something that requires, new ideas. It's not something that requires a lot of thought. It's not something that, you're trying to build a rocket ship to Mars or something. You just look across the country. In Manitoba, the government cooperated with their physicians. They didn't, argue with their physicians and take them to arbitration like our government has had. Came up with a fair deal that recognized that there was some paperwork involved and admin time and had to pay physicians for min time. And Manitoba just had the largest net increase of physicians in their entire history, right? If you look across to British Columbia did the same thing. They recognized that the current model of family practice was not working. They've already done the work to figure out a model that does work. And within a year of introducing a new model of payment for family physicians, and yes, there was a raise in there, but there were some other perks to that model. Uh, 700 new family physicians, similar to Ontario's situation, or similar in the sense that there were 700 physicians in British Columbia who could have done the work who weren't, decided, hey, this is actually what we want to do now. We've always wanted to do it, but now we feel like we're being compensated. So we don't have to reinvent the wheel here. We just look to other provinces where they've already figured it out and just do what they're doing.
And so
right?
what?
Like it just doesn't seem that hard to me. Like I don't understand our bureaucrats and why they don't do that.
Yeah, no, I fully, support exactly what you're saying, especially if it's already been done in other provinces. So what did they do specifically in the other provinces that entice physicians to start practicing again?
Sure. So let's look at Manitoba. I'm just going to pull that province out of a hat.
Sure.
So Manitoba recognized that the administrative costs of running a family practice have really gone up. And yes, there was more payment for family physicians, but they did recognize that there'd be downstream savings to the healthcare system. So, you invest in primary care, you make people healthier, it costs the system less in the long run, right? So they realized that. They recognized that there was a need for family physicians to do a lot of paperwork. So they actually have a payments schedule for paperwork time so that physicians can get paid to actually read all the reports that we read, to all the 19 hours of admin work that we're doing, that there's actually a payment system for that. They recognized that it was not the fault of physicians if patients who were sick decided, the walk-in clinic's 5 minutes away, my family practice office is 15 minutes away, I'll just walk to the walk-in clinic. Because in Ontario, you're penalized in a capitation model as a family physician if your patient does that. So they took that away. And then finally in Manitoba, they've struck a working committee, like a committee that actually works on reducing paperwork in family practice offices. And they've come up with a number of recommendations. Whereas in Ontario, yes, the OMA and the Ontario government have a committee to look at reducing paperwork for family practice. And after 1 year of work, the only recommendation they came up with was, okay, family doctors don't have to sign hearing aid forms if there's an audiologist who does the hearing test. The problem is half the hearing tests are done by hearing aid specialists, not audiologists. So I'm still getting the forms to sign, right? So that committee, after 1 year of work, has done. I
Nothing.
can't say what I want to say because I guess this is a PG rated podcast, so I can't really tell you what that committee's done. But so put a working committee in, and again, like just do what works. Don't try and come up with new ideas.
Yeah, I agree. Like the uh, pay structure and what they implemented in those other provinces, particularly with like the capitation with going outside of the basket. And for people who aren't familiar with that, basically what happens is if you're in a certain full model in Ontario, and one of your patients goes to another clinic to get treatment, then you're as a faux physician, you actually lose money, which is very, very odd. And so patients are basically like deterred from going to other clinics if they're sick. And so I think that one is a big one that needs to be eliminated, because I think a lot of people or a lot of physicians in Ontario are pretty disgruntled with that one, because it just seems like it's not really benefiting anyone in the long term. Like I'm not really sure why that was even implemented to some degree.
Well, and you see, here's the thing, and this is where it comes to politicians who are absolutely, frankly, gutless. Um, when a patient signs an agreement saying, okay, I'm going to roster with this family physician. So in the what's called the capitation model, for the listeners who don't know, I like to think of it as salary and a performance bonus, right? So we get paid a monthly salary, and then you get a performance bonus if you do certain things that other family doctors don't: work in a hospital, look after diabetics, look after palliative patients, that sort of thing. So that's how I like to explain it to the public, because that's kind of what it is. But when you roster or when you sign saying, I'm going to be a patient of this family doctor, if you read the form that you're signing, that form also says you're going to make every effort to see the family doctor, and that you're going to avoid using other services. Like you're promising that you're going to do that. And I've yet to see the government ever enforce that when a member of the general public doesn't follow that form.
Yeah. So again, another reason why, we need to look at this program and see if there's a better way where we can, get physicians to feel like they're getting paid appropriately for the work that they're doing, and also so that they don't feel like if they have a patient that may go to a different walk-in clinic that they're not going to be penalized for that particular work. And so I know that you do, a little bit of work with, younger residents. I think on some of your blogs, you've had some younger residents, write some blogs for you. And so what is it amongst the residents and the medical students that seems to be right now where family medicine is just not something that a lot of them want to pursue?
Hmm. Yeah, so I taught residents for about 30 years. I've actually just recently retired from teaching. My hospital is at my hospital in Collingwood. They is the headquarters of the Royal Ontario Medical Program. So we got residents floating through our hospital, and my clinic still teaches. Some of the other precept doctors in my clinic still teach. And certainly when you talk to them, I still chat with the residents on a regular basis. I think there's unfortunately just a feeling of, you know, we love family medicine in terms of the medicine, but things are just so uncertain, and it doesn't really seem like we're supported. And the government's making all these decisions where they're not really compensating family doctors appropriately, and they're, my God, I come to your office to look at the patients, and I love looking at the patients, but then I look at all the lab work and the reports that are all miscategorized that you're going through. um, and it's sending them a very, very clear message that this is not something that you want to consider right now. And that's very sad and very unfortunate. And that obviously, for the sake of all Ontarians, needs to get fixed.
Yeah, I think too that statement with whoever it was from the Shoppers Drug Mart, I think it was the CEO of the Shoppers Drug Mart, said that something like 40 to 60% of the things that family physicians can do can be done by pharmacists. And I think there's a lot of, people who are upset about that. And I
Yeah.
think that, the more and more messaging that comes out, if I was a medical student or, and I was applying for residency and I saw, family medicine kind of being almost like it's trying to be like phased out in some ways, I would, be very hesitant about applying for it, because I would say like, hey, like, is this job even going to be here in a few years? Are nurse practitioners going to be taking over? Or pharmacists are going to be taking over? And so are they worried that like it may be almost phased out completely, or that it may just not be the position that they're, trying to get in residency or that they're studying for?
Yeah, and that's part of the sort of the disrespect for family medicine that's going on. When you make again, it's PG rated podcast, right? So I can't actually tell you what I think of that comment.
It's not PG rated. You can
It's
say
not
whatever
PG.
you want.
Okay, all right, fair enough. Well, so I firmly believe, and I'll preface this by saying that I firmly believe that there is actually a role for pharmacists in the healthcare system. I firmly believe there's a role for nurse practitioners in the healthcare system. Um, but I will be clear that what their leadership, or what the leadership organizations of the pharmacists and what the leadership organizations of the nurse practitioners are telling their members is garbage. They cannot replace family physicians. They should not have expanded scope of practice. That's going to hurt the population. We've actually got data in Canada. We talk about, pharmacists. Again, there is a role for pharmacists in the healthcare system. I rely on pharmacists a lot for helping with dosing and medication substitutes with all the shortages and stuff we've had, and I really depend on them. But if you look at Newfoundland, which was the very first province that allowed pharmacists to prescribe for minor ailments, they've got the highest rate of antibiotic prescriptions per capita in the country. And if you look at every other province that has brought in the ability for pharmacists to prescribe for minor ailments, the antibiotic prescription rate goes through the roof. And remember, we're supposed to be reducing antibiotic use because we want to, from a healthcare systems point of view, most things are viral. Antibiotics don't work for most things. And you want to be stewards of antibiotic use so we don't develop resistant bacteria like we're doing. So, from a healthcare point of view, from an overall healthcare point of view, this is really bad for healthcare, and we've got Canadian data that shows that it's really bad for healthcare, right?
Yeah.
So, you know, if you look at nurse practitioners, and again, I firmly believe that there are roles for nurse practitioners in our healthcare system. Uh, I've had a couple of cardiac kids in my practice, so kids with major cardiac issues. When I called down to sick kids to get some advice on the kids, I never once spoke to a cardiologist. I never once spoke to a cardiovascular surgeon. I always got the nurse practitioner on the cardiac team. We chatted, got some really good advice. I really valued that advice. For a while there, my local oncology center was in Barrie, RVH. Whenever I called down to get advice on a cancer patient, I always got a nurse practitioner who was part of the team, who knew the patient, got some great advice, really appreciated the feedback and the input that I got, and really helped me manage the patient. So there's definitely a role. But when you look at settings, when you say, oh, it's just a primary care team and we'll connect you to a primary care provider, and you look at nurse practitioners, the blunt reality is the data is coming in that nurse practitioners are more expensive, order more tests, and have more referrals that cost the healthcare system more. And that's a very politically incorrect thing to say. I recognize that. It will not go over well with some of your audience, just as my comments about pharmacists won't go over well with some of your audience. And I recognize that. But you know what? The truth is what the truth is, and that happens to be the truth. So we are heading for worsening of a healthcare crisis if we continue down this path by expanding roles for allied healthcare providers, like this particular government seems intent on doing.
Well, I want to make a particular note on the comment you made on antibiotics and pharmacists. So, first of all, I'm from Newfoundland, so it's kind of,
It's
it's
no
not
bad.
it's not great to hear that. But with regards to the pharmacist and prescribing antibiotics, so one of the big things, or the two big things, most people get prescribed antibiotics for, in acute situations, most of the time, anyways. Bronchitis and pharyngitis, probably UTIs are up there as well, and there's some other ones
Right.
too, but. Bronchitis, like from my understanding, it's about 95% viral. And when we say
Yep.
bronchitis, we're talking about like the typical cough that people get, or what may be called a cold. And so when people do have bronchitis, it's important for people to know that like 95%. So that means only about 1 out of 20 people should be prescribed an antibiotic. And do you
Right.
find that that's something that you've always felt challenging, and same even I imagine teaching to medical students as well, is that, hey, like most cases of bronchitis are viral. So how do you kind of navigate that? And, what's your message to people out there? Because we do know that, antibiotic resistance is on the rise. And I think it was you tweeted, or maybe you retweeted Dr. Isaac Bozak, I think I'm saying his name right, that said that accounts for about 1 million deaths per year is antibiotic
That's correct.
resistance. Is that correct? Yeah.
Absolutely. Yeah. And so, it takes education of the patient. And and you have to sit down and you have to talk to people, and you have to be polite about it, and you have to say, listen, I've done my assessment. This is what I think will help you, and talk about different medication alternatives that can help. The antibiotics will not help you. You always have to give people the opportunity to say, listen, if you don't improve over the next 3 days with what I've suggested, by all means, we'll take another look at you and reassess things. But it's very, very important to make sure that you educate the general population as well.
Yeah, I think so too. And I think I'm right on the fact that with adults, as though it's a little bit higher than with children with regards to pharyngitis. It's something like over 90% of cases of pharyngitis or sore throat would be viral for adults. And then for
Yep.
children, I think it goes down. It might be 70 to 90. I don't know what the exact number is there, but still it's significantly more on the viral side than the bacterial side.
Yeah, absolutely. And again, that requires education. Now, let's face facts. The bigger pharmacy chains that are promoting the expansion of use of pharmacists, their main goal. So if you look at any of the bigger chains, whether you look at the Rexalls, or where you look at the Shoppers Drug Mart, or where you look at the Walmart pharmacies, the main goal of the CEOs of the pharmacy chains is going to be to make sure that shareholder value is protected. Right? That's their goal. That's the job of any CEO of any public company, and I understand that. And actually, I support that concept in general because at the end of the day, I am a bit of a free market capitalist, so I understand that concept. But in healthcare, when you're dealing with patients, um, would you spend 15 minutes to sit down, talk to someone, and say, this is, I've done my assessment. This is what I think. You don't need an antibiotic. These are the reasons why. Here's a handout on antibiotic stewardship that many of us have now that we give to our patients to just to have some reading material. Or would you spend 5 minutes and give them an antibiotic prescription and make a few bucks on the side in the dispensing fee and in the markup of the antibiotic? And I have to tell you, from the CEO's board, not from the individual pharmacists, because we've got a lot of great pharmacists in Ontario, but the CEOs of these big pharmacy chains, what's going to increase their shareholder value more, right? That's just reality. And again, not pleasant to talk about. I don't like talking about it, but that's just a reality we have to face. And this is why many pharmacists have expressed concerns to the College of Pharmacists of Ontario. That you might have read that there was a report that the College of Pharmacists has actually put out saying that they're aware that the pharmacists who work for these big chains, they feel very pressured. They're told they have to get assessments done in 5 minutes, right? That was what many pharmacists have reported themselves to their college, saying, we need some help to fight back against the corporate structure here, that we're not spending the time that we need to. And the reason for that is very simple. The more people you run through, the more sales you make. The more sales you make, the better the shareholder value.
Yeah, I mean,
It's a real problem.
yeah, it seems like it's a serious problem, and I can see why, certainly, why the CEOs would be incentivized, to roll out that model. But, unfortunately, we already have evidence, like you said, from Newfoundland data that it's led to antibiotic resistance. Just out of curiosity, though, has there been any other issues outside of the antibiotic resistance? Has anything else come up, even if it's not peer review data, just like anecdotal or things that you may have heard in the community?
Yeah, I don't really like talking about anecdotal data because everyone makes mistakes. I've had pharmacists make mistakes. I've had physicians make mistakes, right? So I don't, yeah, I understand the question. Um, at the end of the day, I will simply say that people don't know what they don't know, right? If you've been to 4 years of medical school, if you've been to 2 years of comprehensive care family practice residency, you know a certain amount of things. If you've been to 4 years of pharmacy college, you know a whole lot about medication, but if you've had no training in minor illnesses, there are going to be some things that you just don't know, and there are going to be times where you don't know what you don't know, and that's when you can run into trouble. And that's not to say physicians are perfect. Goodness knows that physicians make mistakes. I make mistakes. I've made mistakes. I mean, that's just human nature. But if we're genuinely looking out for the healthcare needs instead of the convenience or the ease needs of the general population, if we want our society to be healthy, we have to have some very hard discussions about what works and what doesn't work, and what steps will worsen healthcare outcomes for the general population.
Yeah, another thing I'm just kind of thinking at the top of my head too is like, as a family doctor, you go through steps. You go through medical school. The first couple of years, you're not really seeing patients, but third and fourth year, you start seeing patients, and then you see patients all the time when you're a resident. So you get used to seeing patients. Then by the time when you're graduated, you're ready for it. But as a pharmacist, like from my understanding, they don't really interact with patients in their 4 or 5 year degree as far as I know. So, just to kind of like throw them right in there to, start basically seeing patients, it almost seems a little bit unfair in some ways. Like I know they do like consults and things like that, but they're asking them to do something, completely different that they weren't necessarily trained for. And so I could see how that could be an issue for pharmacists as well.
Yeah. So I don't know the amount of training that pharmacists have. I'm not a pharmacist. Again, I really need to emphasize that I have to tell you, I work at a nursing home. And I rely a lot on the pharmacists in the nursing home because that particular population, you really need to tweak the dosage levels of your medications. There's a higher risk of interactions with drugs and stuff. And I get feedback from my pharmacists on what medications we need to cut back on and what dosages I need to change, which I really appreciate. It's stuff I don't know, and I absolutely rely on them. Same thing in the hospital, right? I'm always getting feedback from hospital pharmacists, and I very much appreciate their input. Um, I just, you know, I don't think it's fair to ask anyone to spend a little bit of time saying, okay, these are the common conditions. Let's, bladder infections, let's say. Oh, it's just a bladder infection. This is what the symptoms of a bladder infection are. This is the preferred antibiotics. Go to it and treat someone. Because yes, there's times when it's just a bladder infection. And there are other times when you have to sit back and say, well, listen, this is the fourth bladder infection in the past 2 months. And wait a second, we don't have a culture back, and looking at your urine dip, which I don't know if pharmacists do or not, I don't think they do, doesn't show any white blood cells. So even though the symptoms match, it's not a bladder infection. There's something else going on. So not knowing that other stuff that you should know, and worse, maybe not being taught that you don't know that other stuff, I think has significant long-term implications. Um, I think every patient in Ontario deserves to have a healthcare team. I think every patient in Ontario deserves to have someone who provides coordinated care, where all of their records are coordinated in one place and not fragmented, like if they go to different allied healthcare professionals without sort of linking up with them. And quite frankly, the current government's approach to this, it's based on convenience. It's based on, oh, maybe if people find it easy, they'll say, hey, this is great. And actually, there's unfortunately some evidence to support that. And maybe if people are happy and feel this is great, they'll vote for us. It's not based on healthcare items in any, in any way, shape, or form.
In terms of primary care, do you ever think that there could be a model maybe where there's two different types of primary care providers? So you have one type where you go for chronic management of diseases, and then maybe other clinics or just walk-in clinics where you go for acute things like infections. And do you think that would help solve things, or do you think that would maybe just create things or even make more confusion and make things worse?
Well, I would argue that that's what we have now, and I think that that's a decent model. You make appointments with your family doctor. So my patients make an appointment to see me about their ongoing issues, for their checkups, for the diabetic checkups, for assessments of this. And yes, occasionally they'll come to see me when they've got acute illnesses. Um, and then I'm required, as part of the agreement I have with the government for my family health organization, to be part of an after-hours clinic. Sometimes I work shifts there, sometimes other physicians work there. So if it's after hours for those acute things where people have those infectious illnesses, they will go there. But because it's part of my organization, the reports when they go there are automatically part of their patient chart in my office. So everything's coordinated. I see that they've gone there. I get a chance to review what was done. And so I'm aware of their ongoing healthcare needs, right? And so I do think that that's a model that's already in Ontario. I think it needs to be expanded throughout the rest of the province. I don't think it's done in enough places. I think, what's the statistic there, Mike? Is it only 25% of all Ontario residents are part of a healthcare team, or have access to a healthcare team, something like that?
Something like that.
Yeah. So I would argue that we do that. We just need to do more of it.
Yeah, I would argue that we do already do it to some capacity as well. It's not really like, said out loud, and I don't think people are necessarily even afraid of saying it out loud. It's just kind of as a system that's more or less just fallen into place. Because generally speaking, a lot of people, used to just have one doctor that they would see, more or less for everything, unless they need to be referred to a specialist, as their family doctor. Like I'm sure when you said you've had, patients for 32 years, some of those patients have, probably almost only seen you as a family doctor, But that doesn't, we have less and less of that now. But
Yeah.
I do see your point though, that right now there kind of are two models, and I don't think it necessarily was something that was thought out of. It just kind of happened. And it probably is something you have to do with too, just going back to the number you said at the beginning of the podcast, like 16,000 and then 9,500. So like we're talking about 9,500 family physicians, like those people have rostered a family medicine practice. And so
Yeah.
the other 7,500 don't. So I would obviously be in one of the other, 7,500 because I'm mostly working at walk-in clinics
Mhm.
these days. So in terms of, that model, I think that could kind of work, in the future. But should we try to, I guess do something about it where it would be easier for patients to understand, like, hey, okay, this is my doctor that I go to when I, have an illness or an acute thing that needs to come up, and then I have another doctor where I go to if I have something chronic. Like, I think sometimes people fall into that, but we don't really have it like a system overall. Like, do you think that's something that we should roll out or we should talk about, or what are your views on that?
Yeah. So, the hardest thing for a politician to do, and this is a real problem, is to emphasize the need for some patient accountability in the healthcare system. Our healthcare system, I know it's under stress and it's certainly, well, frankly, it's in a crisis. But the reality is, it's still a whole lot better than healthcare systems in certain countries in the world.
For sure.
And in order to preserve it, in order to preserve it, each and every single patient has to take some responsibility for how they use the healthcare system. It's a two-way street, right? It can't just be, it just can't be given to you and say, "Hey, there it is, and go use it as you want." No, you have to take some responsibility for how to use it. And our politicians are gutless cowards, and whenever you try to introduce a method of ensuring patient accountability, like that form for when you roster with a patient and the patient signs saying, I'm going to agree to always come to my family doctor unless I think over 100 kilometers away or whatever, and they go to a walk-in clinic, 5 minutes away instead of calling the family doctor's office, and nothing happens to that patient. There's no accountability. There's no, hey, you promised to do this, and then you force the doctor to use accountability and the doctor to send the patient a letter, which winds up in the news, right? This doctor told me that, oh, this is terrible. I should only go to the emergency, right? You've all heard those stories, right? Um, and I'm sorry, but we're creating a society of, we're not creating a society of empowerment. We're creating a society of entitlement, where people just feel they're entitled to, you know, use things as they want, and that's just not going to lead to a good outcome. Just because you can go to the emergency department every day doesn't mean you should,
Yeah,
right?
I
You have to
agree.
use the system properly. And so we need some controls, and we have to start talking about some reasonable ways of making sure that patients are aware that they have to take some responsibility for how they use healthcare.
Yeah, I think that's been I mean, even when I was a resident, and that's, well over 10 years ago now, they were talking about that in the Emerge, how like there were some people who would, they would show up to Emerge over 100 days in a year,
Mhm.
and so, those patients are obviously costing the government, a lot of money. There's got to be a better
They're
way.
not costing the government, Mike. I really want people to stop saying that. They're costing you money. They're costing me money, because it's not government money. That's the biggest thing that gets on my nerves when government says that. It's taxpayer money. It's my money. It's your money. It's every one of your podcast listeners' money that you pay for in taxes that's getting wasted. Right? Stop saying government money, please.
No, I agree with you. It is. It's taxpayer dollars that are paying for all that. And yeah, we should be upset. And when you talk and when you say, taxpayer dollars instead of, government money, then it does really, kind of, you know, um, get to you a little bit more and make you feel like, this is something that really does need to be fixed. And I do agree with you. We do need to have put a little bit, I think, more onus on the patients as well. And, this is little bit of different topic, but still the same topic is, you know, we have an aging population, but we also have a population that's much more obese, much more inactive, doesn't exercise as much, you know, on their phone more, you know, staying up late, not getting proper exercise, not getting sunlight, all these kinds of things. And so, you know, the more people we have in the system like that, the more the system is going to get overwhelmed. You know, I obviously I don't know exactly what the numbers would be like, but if, you know, the rates of obesity were 10 to 20% or 25%, say like they were maybe in, you know, in the 50s or the 60s, you know, a long time ago now, I imagine that, you know, healthcare and practicing family medicine would be a lot, you know, easier. But, you know, when someone comes in and they haven't done blood work in a long time, and then you see they have, you know, they not only do they have high blood pressure, but they have, you know, high cholesterol, high triglycerides, you know, they just found out they're diabetic. Then they find out that, you know, they're hypothyroid. Like there's a lot to manage there in, you know, one visit and, you know, in one person. And so when you have, you know, patients who are taking care of themselves a little bit easier, it makes it easier on the physician. And I think that's, you know, why some of these people too are leaving. And coming back to the 16,000 and 9,500 physicians who are practicing in Ontario and the ones who are eligible to practice. You know, I think that if there was less patients who, you know, were so complex, you know, more physicians would probably be attracted to practicing medicine.
Yeah, you know, that's a very challenging topic. There's a whole bunch of reasons for the increase in obesity in Canada. You know, y- and some of it, frankly, we're just starting to really discover and look at, whether you're talking about the exorbitant amount of ultra processed foods in our diet, which are very bad, the high amount of processed carbohydrates and the high rates of fructose corn syrup that are just about it, and seems to be in everything, which is obviously very, very bad for the system. Um, so, you know, that part is certainly, it'd be nice if we were healthier, and you're right, there needs to be a fair bit of emphasis in public health to say, you know, we're going to start banning some of these products that are really bad for us. We should have banned trans fats in 2002. It's 22 years later, and we still haven't done that. And certainly ultra processed foods are bad, and we should be limiting the amount of ultra processed foods in our diet and regulating them like the Europeans do. One of the reasons the Europeans aren't as overweight as we are is because their food rules are really a whole lot stricter than the ones in North America. So we should be following their example. Um, that's that's a bigger problem though than the actual patient responsibility aspect of it. I'm talking more in terms of how people use the healthcare system when it's appropriate, making sure that there's you know, a certain, you know, something to make people think that, hey, do I really need to go? So I'll use Ireland as an example. One of my friends is a physician in Ireland. If you go to the emergency department in Ireland on a weekend, you're charged, right? Unless you've got a referral note from the urgent care clinic that their doctors run, which is usually, you know, a mile or two away, and for certain conditions, for what is commonly referred to the CTAS 4 and 5 conditions. So that's the trauma scale, where I know you know what it is, but for your listeners, that's it talks about how serious the condition is. And 4 and 5s are things like coughs, colds, low-grade fevers, you know, urine infections, for those minor things. And what that means is that the urgent care clinics, which are obviously, they're like walk-in clinics, they're much less expensive to run than a full functioning emergency department. What that means is residents of Ireland will go there, and if the doctor who sees them says, "Oh, there's something more than a cough or a cold," then he writes them a note to go to the emergency, and then there's no charge. But if they just go for convenience sake or whatever, they're charged, right, to attend the emergency department for those conditions. And that is a very simple kind of deterrent. It's not, no one's denied healthcare, because you can still go somewhere else, right? And you can still access the healthcare system. Ireland also has a deductible, which is something that we should also be looking at in Canada. But it's not like people are told, oh, you won't get health care. But it's just that little thing that makes people sit back and say, okay, I feel like I'm sick. I need a doctor, but do I want to go to the really expensive place? Do I think I can get away with going to this less expensive place, even though the wait might be longer there or whatever? It's those kind of things that we need to be looking at.
What about even
And
just like
politicians won't, but
what about even just like a $5 copay, or maybe make it
yeah,
$10, something like that? Do you think that would be reasonable solution? Or
absolutely. If you look, and this is very unpopular to talk about with the Canada Health Act, but if you look at every single country in the world, every single one, Denmark, Finland, which are the two that uh, Jane Philpott, who's now head of the primary care action team, she always loves to talk about Finland. Tara Kiran, who's also big on primary care reform, she loves to talk about Denmark. You know what they have? They have a universally funded public healthcare system with deductibles and with a parallel private healthcare system. And every single country that you look at that has a better healthcare system than Canada has that. That's just a fact of life. Whether you like it or not, you can't deny that, because that's reality. In Finland, which is what Dr. Philpott loves to talk about all the time, how wonderful Finland is. When you go see a doctor, you pay out of pocket, and you pay up to, I think when I studied this, it was 2,000 kroners, which is the equivalent of $250, right?
oh wow,
Once you hit $250, like once you used up $250, the government kicks in and pays the rest, right? So that's your deductible for the year for your healthcare services. So God forbid you get cancer, a heart attack, a stroke. Obviously the 250 gets used up very, very quickly, and everything is covered. Everything else is covered. You're not going to go bankrupt as a citizen of Finland. You're not going to lose your house because of a healthcare need. But there's that little bit there that makes people say, okay, I've got to use this system responsibly, properly, and well. Same thing with Denmark. Denmark has a deductible in their public healthcare system that Dr. Karen loves to talk about. Um, Tommy Douglas, the founder of Medicare, who in a CBC poll in 2004, I think it was voted the greatest Canadian of all time, right, for founding the Medicare system in Canada. Tommy Douglas believed in user fees, right? And that will surprise a lot of people. In 1964, I think it was, he gave a speech to the Saskatchewan legislature. At the time, user fees were called a per capita tax. That was the phrase they used at the time. And he got up and he said, I firmly believe we should never get rid of the per capita tax. I would like the per capita tax to be as low as possible and nominal if possible. But I firmly believe that if you have this, it gives the person who uses the healthcare system a sense of responsibility, a sense of worth in their healthcare system, and it conveys upon them the need to use our healthcare system properly. And this is Tommy Douglas, right? So if you want to sit back, and I don't know how many of your listeners are not of this mindset, but if they're saying, "Oh, this guy that I got on your podcast, he's un-Canadian for suggesting we go against the Canada Health Act," well, guess what? Be fair about it and say that Tommy Douglas was un-Canadian as well.
interesting. Yeah, I definitely didn't know that information about Tommy Douglas. Well, your point though too, you made about the copay. Did you say that they had the copay or the deductible, and also they had private healthcare as well, or is it just the copay?
No, all of it. So Finland has the deductible. Denmark has a deduct. I don't know what Denmark's deductible is. Both countries have private parallel healthcare systems. So does all of Europe, right? Like the only three countries in the world, I believe, where there isn't a private parallel healthcare system is North Korea, Canada, and Cuba. So it's not like, we're in some very strange company, right? We're not in a company of the G20 countries in any way, shape, or form. Our biggest problem, quite frankly, is we happen to be right next to the United States. And people always compare us to the United States and say, well, we're so much better than the United States. And we are, frankly, from healthcare. No one's going to deny that. But the United States doesn't have a universal healthcare system as well. Right? They don't. They're the complete opposite, and they're a complete disaster. And we should never compare ourselves to the United States. We should never aspire to be like the United States. But if we want to aspire to be like Finland or Denmark or Germany or Sweden or all of these countries that do so much better on healthcare metrics than we do, France even, Turkey, frankly, even Turkey does a whole lot better on healthcare than we do. Then a good, honest, hard look will show that all of these countries have a universal healthcare system that's based on an insurance philosophy. So on an insurance plan, you have a deductible for everything, right? The deductible varies, and they all have parallel private healthcare systems.
So
That's
I
just what they are.
I understand why the deductible may make patients more aware, more responsible of using the healthcare system. But why would, and I'm certainly not disagreeing with you, but why would introducing private healthcare help the public system?
So if you look at trying to think of what country would be best from when I studied. Let's look at Australia, just for an example, right? Australia has a universal healthcare system with deductibles. They also have a parallel public healthcare system. And the argument that's made by people who say, well, yes, the rich are buying healthcare and getting care quicker, is they always talk about cataracts. So in Australia, if you go to to a private healthcare provider, you can get your cataracts done within a month. If you go through the public system, it's a 4-month wait, right? And that's real, and that's the reality, and I would not attempt to dispute that. And that's because the private clinics, they run more efficiently. They're doing cataracts all the time. You can do many more cataract surgeries in a private clinic than you can do in a hospital with all the bureaucracy and inefficiencies in a hospital that does 100 different things. Having said that, in my neck of the woods, to get right now, for one of my seniors to get cataract surgery at a hospital is about 14 to 16 months. Um, and, my argument would be, well, have you ever thought of asking the seniors? Have you ever thought of saying to them, listen, if we allowed some private clinics and other people, yes, they'd get in 1 month, but your wait time would maybe cut down to 4 months instead of 14 months. What do you think of that? Like, would that be worth it to you? I don't see anyone asking that question. I've never heard of anyone asking that question.
I mean, that's my understanding. Just thinking like logically, you would think that like, okay, there's, a bunch of people in the, or everyone is in the public system now. If we take a little bit of some people from the public pool and put them in this new private pool, then in theory, there would be less people in the public system. I mean, that's how the way I see how it would, benefit healthcare in Canada. And then obviously, for the people who are able to pay, excellent, like more power to them if they're able to get faster care. But I see that it benefits both people, and is that sort of what you would see would happen too, that we have, fewer people in the public pool, and then because of that, people would be able to see faster. Like when you're saying, instead of it being 14 or 16 months, maybe it'll just be, 4 months because there'll be less people in line. Is that essentially how that would work?
So again, all I can tell you is what the data shows, and if you look at every other country in the world that has healthcare metrics better than ours, and keep in mind, because someone's going to say that I want two-tier American style healthcare, like one of your listeners going to say that, right? I will say for the record that the United States is much worse off and has much worse healthcare metrics than Canada. But if you look at every single other country in the world whose healthcare data and metrics are better than Canada, that's how it works in those countries.
Yeah.
That's just a fact. And is it palatable for Canadians who've grown up under Monique Bejan's Canada Health Act? Maybe not. Is it something that is very controversial in Canada? Absolutely. That the facts don't actually care whether you like them or not. The truth doesn't care whether you like it or not. It just is.
Yeah. I mean, if you want a better healthcare system overall, then maybe we need to reevaluate things. I know that we only have a couple minutes left, and but there's just one kind of burning question, part in the pond actually, that I wanted to ask you about. So burnout in family medicine, and I see all the time, whether I'm on the OMA website or CMA, wherever it is, it seems like there's always articles about burnout in family medicine, burnout in medicine in general, actually, not just family doctors. So
Mhm.
is this something that you've seen with residents, with your colleagues? Like, is this a big concern that's been going around in amongst family medicine circles?
Well, and it's not just family medicine. I've seen it in family medicine. I've seen it amongst the specialists. I've seen it in nurses. I've seen it in pharmacists. I've seen it in nurse practitioners. I've seen it in PSWs. Like because our healthcare system is so disjointed, so fragmented, frankly feels leaderless right now. Our healthcare system just seems like it's kind of rudderless and not going in the right direction. I think every healthcare worker, regardless of what role you have, there's a significant amount of burnout in all of those professions, and it's very, very worrisome. I see a compassion deficit happening, which really upsets me because I think, no matter what you think, you should really try and care for people and look after them and show them some compassion when they're sick. But I see this compassion deficit amongst doctors, nurses, pharmacists, PSW, like the whole gamut. So it's a huge, huge problem, and frankly, our healthcare system really needs some leadership, some direction, and someone to say we're going to go in this direction, and this is how we're going to fix things, and we're do the hard things that need to be done to fix things, and we don't have that right now.
Yeah, I think that we do need some leadership, and someone really to coach the residents, coach kind of new doctors as well. Like if there could just be like a group of people that say, like, once you finish school and you get set up in your practice, whatever, if then to just come in and kind of make sure that everything's okay, ask questions, ask about the EMR. Like, I'm just getting into AI scribe now. I think it's relatively new, so I don't think I'm way behind the curve on that, but still, it's just something that I just kind of got lucky. Like, the person who owns the walk-in clinic where I work, they're a fantastic individual, and they just made sure everything was perfect. They installed like the tail software onto my computer for me, and I just kind of got super lucky because I had some really good people around me, but everyone doesn't have that, and
Right.
I think that we could put more of a focus, I think, on that. Just helping people get started at first, I think, would be really helpful.
Yeah.
But anyways, I know that our hour is up, and I can't thank you enough for coming on.
You're welcome.
I did have a couple more questions, but our conversation was just so interesting to me that I couldn't not ask some other questions that I want to ask. So thank you so much again for coming on. Is there anything in closing that you wanted to share, Dr. Gandhi?
Yeah, I just would like to thank you for having me. I always enjoy talking about healthcare. Um, I want, at the end of the day, I want a really good healthcare system for my patients. As I mentioned at the beginning of the podcast, I feel really blessed to be looking after the people of Stayner, which is where my medical practice is. They're good, hardworking, decent people. They deserve a good healthcare system. Um, and so I want to try and advocate for the best possible healthcare system for them. And I firmly believe that, you know, the politicians are not doing us any favors in getting that healthcare system, unfortunately.
And tell us too about your blog, justanoldcountrydoctor.com, and your Twitter handle for everyone who wants to learn more about you.
Yeah, so if you want to read my blog, it's www.justanoldcountrydoctor.com. You can subscribe to the blog, and there's oftentimes information on healthcare. There's oftentimes information on other things in the healthcare system. So be happy for you to read that. And on, I guess it's called X now.
Yeah.
It's at Dr. MS Gandhi. So that's DrMsGandhi.
Awesome. Okay. Well, thank you so much again for coming on. I really do appreciate that. And thank you to all the listeners. I appreciate you guys listening, and I'll be back again with another episode soon.